My name is Joni Slager, and I'm the Dean of Nursing at Frontier Nursing University. Happy Rural Health Day. I'd like to welcome all of you to this session titled Coding and Billing for the Complex Outpatient Visit. It probably bears discussing for a moment how the Dean of Nursing became a coding and billing expert, and I will tell you it dates back to my clinical days in which I was an attendee of a workshop on business concepts and filling out an evaluation form about what other topics might be considered in a future conference. I suggested billing and coding because at that time in the early 1990s, the billing and coding rules were shifting. And so be careful when you put those things on a conference evaluation because it ended up in me doing a workshop at the next year's meeting. And so in training myself and educating myself to do that workshop, I learned some fascinating things. And many of you that are clinicians have been in the position I was in which a billing person or some other person in the organization where you work would say, I'm not sure that you can bill for that, or you can't bill for that, or we can't bill for that. And I learned that there was a lot of services provided that we can and should bill for. I started implementing what I was learning in my own practice. Now, I'm not promising anybody these results, but within 1 year, probably because we were very bad at billing, we tripled our billed revenue. This talk is not about loopholes or tricks to do something illegal. What it really is capturing the hard work that you do and translating that into billing for services that then result in reimbursement. So I have done some independent consulting for a while, and I never went to a practice and said to them, boy, you guys need to work a lot harder. What usually was uncovered as a result of visiting and looking at their practices was that there was a lot of money being left on the table, a lot of work that was being done and not captured by using appropriate billing. So today we're going to talk about billing and coding concepts that can be applied specifically to outpatient visits because that crosses most specialties. I will give you a disclaimer right up front. I am a nurse midwife, so many of my examples are women's health type examples, but I will try to help you translate those into the primary care and specialty arena whenever I can. And if you have questions, we'll be keeping an eye on the chat box. So please feel free to be interactive and clarify anything that isn't real clear. I also, at the very end of the talk, I'm going to present a few exciting announcements about how this is going to get even easier. There are some billing and coding rules and changes that will go into effect at the beginning of 2021. And so I'm going to just kind of preview those for you so that you can have the kind of a sneak peek into what's coming and how billing and coding and choosing the evaluation and management code for the visits that you do will become even simpler as we head into the future. So we'll share that and some exciting news for preceptors as well in terms of some billing and coding changes. So that's what we have in mind for the next hour. And with that, we'll go ahead and go on. And Stephanie, I don't see that I have moderator privileges just yet. There we go. Okay. Thanks. So whenever we're going to talk about billing and coding, we have to keep in mind that there are 5 basic umbrella rules that govern all of the billing and coding laws and the requirements for how we do things with respect to billing and coding. So first of all, a payer, which is like an insurance company or someone like that, Medicaid, Medicare, they pay for services that are included in the covered benefits. So things that are considered elective surgeries or elective procedures are typically not covered. So in order for them to pay for a service, it's got to be a covered benefit. The service needs to be provided by a qualified provider. So you have to be credentialed with that insurance company. They have to know that you are appropriately educated and licensed and able to provide that service. So we'll talk about that at the end of the talk when we discuss briefly a little bit about working with students. But that's why there are some regulations surrounding working with students, because the payers need to assure that their enrollees receive care that is provided by a qualified provider. The most important thing on this list that we'll talk about in a few minutes is being medically necessary. So in the coding world, we have two sets of codes. We have a set of codes that describes what we do, and we have a set of codes that say, why did we do that? And it's very important that the why we did it code is accurate, because the number one reason that providers get their bills rejected is because the medical necessity is not established when the bill is generated. So we'll talk about establishing medical necessity, because that is probably the most important regulation that the payers have. Documented in the medical record, and we'll talk very briefly about that. Back in the day when we were all living on paper, I can remember writing performance improvement plans with several of my providers at their annual evaluation because their documentation was not legible. And if it's not legible, then it's considered not documented. But the advent of the electronic record has certainly solved problems, and I could stop writing those in the annual evaluations. But there are some rules surrounding documentation that we will talk about briefly. And then the last thing is coded correctly, and that's where we'll spend the focus of most of this talk, is on choosing the correct codes that represent the work that we do, so that a clean bill is generated that then hopefully translates to appropriate reimbursement. So we have this coding alphabet. And I'm sorry, these words turned out really small in Big Blue Button. They were much larger in the Google Sheets where they were created. But we have this alphabet, and I can remember taking my first post-test or pre-test in my very first billing thing. What's a CPT code? What's a modifier? What's at that time an ICD-10 code? Never heard of them. And so we have this kind of new language that we have to learn with respect to coding and billing. So the big code set that concerns most of us, or 50% of the coding, is the CPT codes. Now, this is called Current Procedural Terminology, and we're in revision 4. These codes are owned by the American Medical Association exclusively. So if those of you out there are wondering, why don't we have codes that represent the really cool things that we do, this may be one of the reasons, is that the American Medical Association owns these codes. They are the only ones that can change the definitions or add codes or delete codes. Now, I have been the American Nurses Association representative to the AMA CPT Update Committee. So definitely, as advanced practice providers, we have representation, but this committee is owned by the AMA. So I don't want you to think that we have absolutely no input. In fact, I've been there to provide input, but it is something that the code set is exclusively copyrighted and maintained by the AMA. The ICD-10 codes, and ICD-10-CM stands for clinical modifications, have many groups that impact the code revisions and changes. And these codes are copyrighted by the World Health Organization. And the reason that the clinical modifications is added when we talk about billing is because ICD-10 and actually 11 and 12 live in the world. They are primarily used for morbidity and mortality reporting statistics, but because we in the United States use them for billing, the clinical modifications is the modification that is applied to ICD-10 codes that then allow us to use them for documenting medical necessity with respect to billing. So that's what that stands for and how those codes are used by us. So CPT codes, the current procedural terminology codes, determine how much we get paid. Each payer or insurance company, Medicaid, Medicare, for every CPT code, and those are the codes that represent either procedures, outpatient services, office visits, hospital visits, emergency visits, skilled nursing facility visits, all of these are represented in the CPT code book. There's about 75 to 100 to 8,000 of them. And then the payer has a grid that for this CPT code, this is the payment amount that is allowed. So applying the correct CPT code will represent how much you get paid according to what is established by the insurance provider or the payer. Within the CPT codes are a chapter called the Evaluation and Management, or E&M codes. And these codes are exactly what they say. The patient is evaluated and then management is determined. So these are codes that are represented in broad categories like office visits, hospital visits, consultations, things like that. This is when a patient is seen by a provider, the patient is evaluated, and a management course is determined, as opposed to procedure codes that have a defined skill set, specific procedure and what is typically a part of that procedure. We have evaluation management codes for radiology and laboratory services. We have them for general medicine. We have them for anesthesia. If you ever want to, just for the midwives on the talk, if you can imagine, take a look at the anesthesia codes. Can you imagine a world where we could bill by the minute? And that's what anesthesia does. And not only do they bill by the minute, but no one ever questions the medical necessity of anesthesia. So billing is a much smoother path if you're in anesthesia. So we also have some subcategories that live in evaluation and management. We have, for example, office visits, which we have to separate into whether the patient is a new patient or an established patient. We have subcategories on hospital visits, where you must establish whether this is an initial encounter in the hospital or a subsequent hospital day. There are other very broad subcategories like skilled nursing facility, home visits, things like that. But we're going to focus mostly today on the outpatient office visit. The ICD-10 codes then are called the International Classification of Diseases, and we're currently in this country using the 10th revision for about 4 years now. They describe a diagnosis, symptom, condition, or complaint to why the patient came and received services. They establish the medical necessity. And for those of you that look at public health statistics, for example, the publication the CDC puts out, the MMWR, the morbidity and mortality report, then the diagnosis codes are used to generate that data. So these are the various uses or how this ICD-10 codes are used. So where CPT codes determined what you got paid, so each payer looked at what do we pay for a 99213 outpatient visit, for example, then the ICD-10 codes determine if you get paid. If you don't attach the appropriate diagnosis or a diagnosis that makes sense to a CPT code, then that will result in denial of payment. And it is possible to have up to 4 ICD-10 codes for each CPT code. Now, 4 codes are not necessary. I would recommend that you attempt that, but it is possible if the patient presents with more than one diagnosis, as often is seen in primary care, where multiple issues are addressed in the same visit, then you can attach more than one CPT code to, or ICD-10 code to a CPT code, but they do not, it is required at least to have one. So the diagnosis codes then establish the medical necessity for a procedure, an outpatient visit or service, inpatient admission, lab work or medications, or for ordering imaging. When the electronic health records started, it forced us to associate a diagnosis with everything we ordered, whether it was a medication or an x-ray or an ultrasound. And it used to be, I did some pushback initially when I didn't understand this as a billing necessity. When ultrasound would say, you ordered a limited ultrasound, you know, what's the diagnosis? And I would think, you know, do it because I said so, I guess, you know, but they need to have that medical necessity so that when that ultrasound is coded, that they can attach the diagnosis to it. So it's very important that we learn to associate diagnoses. And it's important to use them correctly so that the bill is done appropriately. For example, if you're a midwife ordering a post-dates ultrasound because the patient is 41 weeks, you can't attach just fetal survey as a diagnosis because that diagnosis doesn't match with the ultrasound code that's going to be billed for looking specifically at the baby because the woman is post-date. So it's really important that we carefully consider the diagnoses and not just pick any arbitrary diagnosis in order to move on in our charting. We often are also encountered within office outpatient visits especially as APRNs, not all of our patients come to us with a problem. They don't all present with a diagnosis, symptom, condition, or complaint. So we have a subset of the evaluation management codes called preventive visits. So we see these in well woman visits, in annual visits for adults, and well child visits. So we have our problem visits, and then we also can have our preventive visits as well that have a little bit different requirement in terms of coding. So if we are going to understand and learn to correctly choose the right evaluation and management visit, it's important that we understand the key components that make up the formula that help us choose the correct level of outpatient visit. And those three key components are the history that we take, the physical exam that we perform, and then the medical decision-making that is employed, whether that includes ordering imaging or testing, ordering medication, advising the patient with lifestyle changes, whatever the medical decision-making involves, then that is the piece that really documents the work that is done in a visit. And then we also count the elements of history and physical exam. So there are some contributing components. Oftentimes the history, physical, and medical examination part or medical decision-making part doesn't quite capture what went on in that visit. So there are some contributing components. Then what if we spent the majority of the visit counseling the patient, or maybe coordinating the care? We need to make some referrals or involve other providers. Maybe the presenting problem is of a nature that the problem is more compelling than what the amount of physical exam and history taking involves. And then the last thing is, what about the time? What if the time is really the determining factor for the level of the visit we do? So we'll be talking about those kind of things and what contributes to choosing the correct code. So let's take apart those key elements for a moment so that we understand how we evaluate those and how they apply then to choosing the correct code. The first key element is the history part of the service. So of the history, we have 4 pieces, and that is the chief complaint, the history of the present illness, the review of systems, and the patient's past family and or social history. So when we look at a chief complaint, the chief complaint is required to be documented for all evaluation and management visits. So this is the reason the person presented for services. This may be the condition they have or the symptom they're experiencing, whether it's pain somewhere or a headache, or they have a sprained knee, or they have trouble breathing, or they have nausea and vomiting, whatever it is that is bringing them in to be seen. The documentation should, as much as possible, be in the patient's own words. So it should be what they say they are coming in for. And then it should be specific. So if you write here for recheck and I'm auditing your chart, I don't know what you're rechecking. So, here for follow-up after receiving treatment for ear infection, or here to recheck position of IUD or something like that. Be more specific when you are documenting your chief complaint whenever possible. The history of the present illness then is, what is the nature of that chief complaint? When does it happen? How painful is it? Is there a certain time that this is worse? What makes it better? Has the patient tried anything? Are there any associated signs and symptoms? If they have nausea and vomiting, is there abdominal pain? Is there diarrhea? Any difficulty breathing? So what are associated signs and symptoms? Again, what have they tried that makes it better? Does it make it better if they are stopped moving? Does moving make it worse? How would they describe the quality? Is it a stabbing pain, a sharp pain, a dull pain? So these are all elements of the history of the present illness. The next component of the history is the review of systems. So that's looking at individual body systems and doing a review of those systems. For example, if someone presents with abdominal pain, we might ask, well, have you had any nausea and vomiting? Have you had any difficulty breathing? Have you had pain anywhere else? Any headache associated, difficulty swallowing, things like that. So those would be how you would evaluate other systems as related to the system that the patient presents to address. These are the organ systems that are identified in the CPT code book. So these are the various organ systems that you might consider in your review of systems. So past family social history. Examples of the past history might be any childhood illnesses, other chronic illnesses, any hospitalizations, accidents, operations, current medications. Looking at family history, and this would be family history as it applies to the particular problem. So this would be any inherited or chronic illnesses experienced by the family. And then the social history could include comments about employment, the patient's education, any illicit drug use or other drugs. Sometimes we forget to include over-the-counter medications when we're taking a past history. The sexual contraceptive history can be part of the social history. So again, looking at what comprises the elements of a history. So we have 4 categories of history in the CPT codes, and those are problem-focused, expanded problem-focused, detailed, and comprehensive. So these are the 4 categories that we look at. So this grid here shows you that if I am trying to determine the type of history that I've performed, then how much of a history of the present illness is documented, how many systems did I review in my review of systems, and then how many elements of the past family or social history did I perform or document. So for example, if I think I did a detailed history, that means that I presented and documented at least 4 elements of the history of the present illness. So that would be that timing, location, duration, severity, that kind of thing. So at least 4 of those are included in my documentation. I've reviewed at least 2 to 9 systems, and I have commented on the patient's past or family or social history. So I have commented on one of the 3 elements of the past family or social history. In comparison, if I think I've performed a comprehensive history, then I would do an extended review of systems, which is 4 or more. I would do 10 or more systems in review. And for a new patient, I would comment on her past family and social history, or for an established patient, 2 out of the 3 of those. So that would how I would determine if I had performed what level of history. And I have to meet all 3. So I can't say I did a detailed history if I had an extended review of systems, or an extended history of the present illness, I only reviewed 1 system, and then I documented 2 out of 3 of the past family social history. Because I only reviewed 1 system, the highest level of history that I could put in that formula would be an expanded problem focus history. The next piece of the puzzle is the examination. And we have the same 4 categories, so that makes it easy. We have a problem-focused exam, an expanded problem-focused exam, a detailed, and a comprehensive exam. And so this grid will show you, well, this is an example of when I show you what is part of the physical exam. Is this an example of a form that you could find in an electronic record? And you see these dots here, these are called bullets. So many systems have standardized exams, and this is a specialty exam of the genital urinary system for a female. And so you see all of these dots here are considered bullets. For example, in the genital urinary system, you'd have things like external genitalia, urethral meatus, the urethra itself, the bladder, vagina, and so on and so on. So when we look at this next slide here then, if you look at what the history is required, according to some guidelines, you would perform a limited exam of the affected system for a problem-focused history. An expanded problem-focused history would be the affected system plus 2 to 4 others. A detailed exam would require that you examine a minimum of the affected system and 5 to 7 others, and a comprehensive exam is that you examine 8 to 12 in a multi-system exam. Now, there are 1997 guidelines that are very detailed in terms of if you choose one of these levels, then you need to make sure that you comment on a certain number of bullets. So it's hard to see down here at the bottom, but a problem-focused exam would be you need to speak to 1 to 5 bullets, and then for an expanded problem-focused exam, 6 to 11 bullets, and for a detailed exam, 7 or more bullets, and then it talks about the comprehensive exam being either a comprehensive exam of one system or a general multi-system exam. So depending on the guidelines, you either count the bullets of your physical exam, or you would use the CPT guidelines, which are a little broader, and you merely count the systems. So I'd like to spend a little bit more time talking about medical decision-making, because in my experience, where providers tend to underbill or undercode is that they don't give themselves the credit for the medical decision-making that they do. So in considering medical decision-making, we consider the number of diagnoses or management options. So someone comes in with belly pain. The differential can be pretty long. Headache, pretty long differential diagnosis. If they come in and say it burns every time I pee, that may have a much shorter diagnosis option list. We have to consider the amount and complexity of the data that we obtain. So how much lab work do we have to do? How much imaging? Do we have to get an old chart? Do we have to get someone else, like a care provider, to help us interpret the data that we're looking at? And then what is the risk? What is the risk of either what the patient is presenting with, or what do we have to do to them in order to get to a diagnosis? Or once we get to the diagnosis, what is the risk of the treatment? So medical decision-making then is listed into 4 categories. And this is straightforward, low complexity medical decision-making, moderate, or high. So this chart will show you here then, considering the 3 categories of medical decision-making: diagnostic options, the data that you review, and the risk associated with this diagnosis, then we determine the level of medical decision-making that we employ in a specific case. Now, in order to choose the correct medical decision-making level, you must meet or exceed on 2 out of 3 categories. So for example, if we consider, and I'll just throw out the diagnosis that many of us could be pretty familiar with, what if we consider someone who is newly pregnant, established by a pregnancy test, comes in with spotting, comes in with nausea and vomiting, and severe abrupt onset of right lower quadrant pain. So we all start thinking immediately, well, this could be an appendix, it could be ligament pain, it could be gastritis, it could be an ectopic. So we would probably all agree that there are multiple diagnostic options in this case. The data that need to be reviewed might simply be confirming the pregnancy test, maybe doing a pelvic exam or an ultrasound. We should be able to get to the bottom of this diagnosis fairly soon. So some people would say that this is limited data. Some might agree that it's moderate data. And so somewhere in here, whichever you decide. In the case when we might suspect an ectopic pregnancy, the risk was pretty much, we can all agree that this would be high risk. So the medical decision-making in this case, given multiple diagnostic options, either limited or moderate data with high risk, would be moderate medical decision-making, because we have met this on 2 out of 3. Whether we consider these 2 or these 2 here, we can throw out the lowest. So if we think we only performed a limited amount of data review, then we can toss that out and only use these two categories here, of which then is met or exceeded on the moderate level. So that's how we would choose the level of medical decision-making in this particular scenario. And you can apply that same formula over and over again, depending on the nature of the patient's presenting problem and what it is that you do. So the key component of choosing the correct evaluation management code is medical necessity. So when we look at the next slide here, and we see that, well, the next slide after this one, if you look at this slide, we also have to decide before we go to the formula then, is this a new patient or an established patient? So we will determine if this is a new patient or an established patient. And in order to do that, we have to see, have we done any billable services with this patient in the last 3 years? If we have renewed prescriptions, if we've provided phone advice, if we've had them come in for a free pregnancy test or blood pressure check, that does not maintain them as an established patient. But if we have documented a billable service within the last 3 years, then they are an established patient. And if we have not, then they are a new patient. Even if we've delivered 5 of her babies, if we have not documented a billable service in the last 3 years, then they're a new patient. And that's from a billing perspective, not from philosophically, do we recognize her or not when she walks in the door. This is also of a provider in your same specialty within your group. So if you are a big multi-specialty group and an internist sees the patient and sends her to you for services, but they are not in your same specialty, then they can still be a new patient to you, even though they're seen in the same practice umbrella. So getting back to then choosing the correct level visit, medical decision-making must be part of the formula, and we have to determine if this is a new or established patient. So let's take the example of the woman that comes in with belly pain, and we think that she could have a possible ectopic pregnancy. So we've already decided that part of the formula is that we performed moderate medical decision-making. Now, if you look at what level of history or exam you performed, most people, when I've run this scenario in a longer workshop, have agreed that the patient, we did a detailed history. So that meant the chief complaint, at least 4 elements of the history of the present illness, reviewed at least 2 systems, and we documented at least 2 out of 3 for a new patient of the past family social history. So most people would agree that we performed a detailed history. Most people would say that the exam was probably very focused on the belly pain. So that was an expanded problem-focused exam. And then with a risk or a moderate decision-making, especially considering the high risk of moderate medical decision-making. In the case of a new patient, the code that we would have to bill would be a 99202, because you have to agree on 3 out of 3 in the history, exam, and medical decision-making in order to be able to document, to provide documentation that supports a level 2 new patient visit. So detailed, expanded problem-focused, moderate, we drop down to the lowest one, and that would be a 99202. Now, if we'd had the time and the condition warranted a detailed exam, then this would be a detailed history, detailed exam, moderate medical decision-making. We would document and code a 99203. Let's ignore the time for a moment, because that's really not relevant unless you're going to bill based on time, and we'll talk about that in a minute. Now let's take the same scenario and imagine that this is an established patient. And now we only need to meet these criteria for billing on 2 out of 3, but medical decision-making needs to be one of them. So if we performed a detailed history, an expanded problem-focused exam, and moderate medical decision-making, the established patient code would be a 99214. So the take-home from this is you can't memorize either the formula for established or the formula for new and apply it across the board to all patients, because the codes are different. Now, relative value, or applying relative value units, which then determine your level of payment, are different. So a 99202 does not equal a 99212. So the provider can be assured that, gee, if she were only an established patient, I could bill a 99214. And yet, a new patient, the relative value units and payment for a 99202 is probably somewhat similar. So it's more important that you code correctly according to a new or established patient, and the documentation supports that level of code. Now, these times here are not to be used as guidelines to say, well, that visit took me about 20 minutes, so I'm going to round up and consider this to be a 99214. These are when the provider is choosing to bill based on time. And there are some very definite requirements when we do that. When the provider is choosing to bill based on time, these are the time parameters that are used in those cases. So ignore this column if you are choosing an evaluation and management visit based on the 3 key components, as we do most of the time. We'll talk in a few minutes about when and if we want to use time. I also discourage people from documenting the time of a service unless they're going to bill based on time. Because if I'm billing a level 4 and I document that this length of this visit was 15 minutes, the provider could be confused and choose to bill and think I'm billing based on time and discount my payment, saying, well, you documented 15 minutes and that equals a level 3. So I discourage people from documenting the time it took unless you are going to choose to bill based on the time. So within CPT, we have preventative medicine codes, and those codes require that you document a comprehensive history, comprehensive physical exam, so a general multi-system exam. You do counseling and anticipatory guidance and risk factor reduction that is age appropriate, and perform the collection of any lab tests or diagnostic procedures. So these codes are based on age, and they're separated into whether or not the patient is a new patient or established patient. So I know that it's probably a pretty common occurrence that you will see a patient who will often present for a preventive well check, whether that be a pediatric patient or an adult, and yet they also come to you with a list of problems. In fact, sometimes it's the problems that inspired them to schedule that visit to begin with. So when we see a patient that is a preventive medicine patient, they've come in for their annual physical and they have a problem, we have options. We can do the preventive exam and reschedule them to come in to address the problem, which doesn't often feel like the most customer-friendly option, especially if the problem is really what's bothering them. We can address the problem and reschedule the well visit. And I'd recommend that whenever possible, you do it this way, because then you can bill for the problem, address the problem, and then bring it back and do the well visit when the problem's resolved. From a billing standpoint, you're going to get the most reimbursement, and it is the cleanest way to address both of these. But there are times where there's enough overlap with the annual exam, especially in women's health, and the problems they might come in and address with us, that sometimes it makes sense to do both at the same time. Sometimes it makes sense to do a procedure with a office visit. So we're going to spend the next couple of minutes talking about when we might do that and how we might bill that. So your first option is to address the problem and reschedule the preventive medicine visit. So you would bill the evaluation and management code that represents the problem, and then you would bill the preventive medicine visit when they returned for their annual. Option 2 would be to bill the preventive medicine visit and an E&M, an evaluation management visit beside that with a 25 modifier. The 25 modifier says to the payer there was a separate significant evaluation and management visit that was performed on the same day as the preventive medicine exam. So in the case of a well woman, you might bill a 99295, an established patient well woman visit, and then you would bill maybe a 99213 representing the problem that was also addressed and attach a 25 modifier on it. The 25 modifier then says to the payer, 2 things were performed. We did the whole requirements for the annual exam, but there was another problem that stood out and was significant. Now, this should be something that isn't typical, like if it's a menopausal patient and you address menopause, that's part of the preventive medicine visit. That's why you're paid for that visit in the way that you are, because that's an age-related issue. But if it's a breast lump, or it's depression, or it's abdominal pain or pelvic pain that's above and beyond what would be routine and normal for a preventive medicine visit, then you can choose the elements of the history, physical, and medical decision-making that are unique to that problem. You cannot double dip any parts of the history, the physical, or the medical decision-making that were also part of the annual. So sometimes a standalone problem might be a level 4 established patient service, but it might be reduced to a level 3 if it's done with an annual, because many aspects of the physical exam and the history will also be covered in the annual. And so you cannot count those twice. So you will have to carve out the parts that were done separately. Now, there are some urban legends about the notes can't be in the same page, or they can't touch each other, or whatever. And actually, as long as you address the chief complaint of the problem, the history of the present illness, the review of systems pertinent to that problem, and any other factors, what part of the physical exam was specific to the problem, and then what your management concerning that problem was, then that is how you carve out that documentation. And then you attach a 25 modifier onto the evaluation and management code. You can also, in some cases, because there are some payers that don't recognize the 25 modifier, and this is very rare, but sometimes what the payer will ask you to do is go ahead and bill a preventive medicine visit with a 22 modifier, which is an increased procedural modifier. It says that more work was done than what's represented in the CPT code, but really check with your payer before you would just choose that, because this is only in unique cases where the payer will not recognize the 25 modifier, which is more commonly used. So the 25 modifier is used when there's a separate significant problem that is addressed at the same time as another component of the visit. So in the case of a well woman exam, you can't talk about menopause, birth control, diet, exercise, and all that and call that a separate problem. But there are other things that might be more unique and attributed to a problem visit as opposed to part of the annual. So in this case, you would bill the well woman exam, whichever would be the appropriate code for well woman, and then you would bill the appropriate evaluation and management code with a 25 modifier. Now, I would caution you, the patient can only be a new patient one time. So if this is a new patient well woman exam and you choose the new patient codes, when you bill the problem visit, stick with the established patient codes, the 992, 12, 13, 14, 15. You cannot use new patient codes once you've billed her as a new patient for the annual. So make sure that you don't use two new patient codes in the same visit, even with a 25 modifier. She can only be established for one, she can only be new for one service, and then the other services, she's an established patient. And then, as I said, make sure that you exclude elements of the history, exam, and medical decision-making that were addressed in the annual, and you can't double dip those. So if we have a 22-year-old patient who comes in for an annual, she wants to start birth control, then she's diagnosed with vaginitis as well, you could bill the new patient code for the well woman exam, and this is a well woman exam with a problem. And then you could bill a 992 with a 25 modifier, and the diagnosis here would be vaginitis. Now, again, this is all just for an example. The 99212 may be the code that's appropriate. It may not. It depends on the documentation. But this is just an example on how you would use both of these codes to represent an annual with a problem. Depending on the problem, your diagnosis would change, and the level of the evaluation and management code would be dependent on what you've documented. That's addition to the problem. What if you do an annual or another office visit and you do a procedure as well? So the patient comes in for an annual and a cervical polyp is noted and removed. Then what you would do is you would bill the annual exam, whether it's a new or established patient. The diagnosis would be a well woman exam with a problem. And then you've got a procedure that you did as well and the diagnosis for the procedure. Because remember, we attach a diagnosis code to every CPT code. Then you add the 25 modifier, in this case, to the evaluation and management visit, that is the comprehensive well woman. The reason is the 25 modifier can only go on an evaluation and management code. It can't go on a procedure code. So in the case of a well woman exam with a vaginitis, the parent code or the dominant reason for the visit is the annual. So we attach the 25 modifier on the problem. But in the case of a procedure, the 25 modifier can't go on a procedure. So it must go on the preventive medicine evaluation management code, and then the procedure code does not require a modifier. So make sure that you put your 25 modifier in the right spot. But this is a very useful code with respect to billing and coding to allow us to capture dual services done in the same day. Another example would be a patient comes in and wants to know about every FDA-approved birth control on the market. And she decides to go ahead with an IUD insert, and you have the time to do it. So you can bill a evaluation and management visit for contraceptive counseling, and then you can put a 25 modifier on that and bill for the IUD and the IUD insertion at the same visit, because you have a procedure that was done at the same time as an evaluation management visit. It doesn't always have to be an annual and a procedure or an annual and a problem. It can be another E&M service performed on the same day of another service. So here's a little bit of a fun thing that if you haven't done it, you can start adding it to your repertoire, is if you perform wet smears, the CPT code for a wet mount includes either the KOH or the saline, but it doesn't include both. So if you do both a saline wet prep and add KOH, then you should report the 87210 twice. So that's 2 units because you perform both of those services. Now, when we bill Medicare, the Q codes for this service are actually separated out into 2 separate codes. But those of you that are doing wet smears and billing for them, if you're doing both the KOH and the saline, make sure you bill 2 units for the 87210. And this doesn't require a modifier when it's done with a visit, because this is just a lab charge. So it doesn't need any kind of a modifier. So code your E&M visit, code your lab charge for your wet smear. Okay, so what if we do counseling? What if we have a patient such as this one who comes in, she's 35 years old, she wants to talk about infertility. So this is not your typical well woman, head to toe, give her birth control kind of thing. You spend an additional 15 minutes face-to-face discussing fertility awareness, the treatment options, maybe how she would do basal body thermometer or check her mucus or things like that. So you have an additional 15 minutes concentrated on a separate service addressing her concern about the inability to conceive. So in this case, you would do an annual, and this is an established patient, and this is an annual with a problem. If it was without a problem, this last digit would be a 9. And the problem of infertility is then documented as a 99213, 25 modifier, separate service done on the same day. We've got a diagnosis, and then you would bill this. 99213 could be based on the history, physical, and medical decision-making that was done unique to the infertility. But in this case, it was all talking. We really didn't have a whole lot of extra involved. There might have been a little bit more of the history and a little bit more of medical decision-making, but you could very easily justify this to bill based on time. Because when we bill based on time, more than 50% of the visit is dominated by counseling, risk factor reduction, education, reviewing treatment, or things like that. So that's when you remember those new and established patient charts, and it had times, that's when we choose to bill based on time. And these are the guidelines for how many minutes are represented. So if you get this, you would have a 99203 would mean you spent 30 minutes with a new patient. If you spent 28 minutes, you would still choose a level 2 because this isn't a question of which one of these it's closer to. In order to get a 99203 and you're billing based on time, you have to get to a minimum of 30 minutes. So you have to jump to the next level once you have reached the minimum. So Darla says, so in this example, you would, infertility doesn't get billed as a problem annual. Yes, I'm sorry, when you go back to this slide here, this is a problem. This is an annual exam with a problem. If it was without a problem, this would be a 419. A 411 is an annual exam with a problem. And then the problem here is noted with the code for the infertility. So these are the times for new patients, and then this is a reminder of the times for established patients. So again, if 50% of the visit is dominated by education, counseling, teaching, coordination of care, then you can choose to bill based on time. And that's where it's really important that you document the time. And it's good to document it in a fraction, like 30 or 40 minutes. So in this case, you could say an additional 15 of 15 minutes was spent face-to-face talking about fertility awareness, the workup, how to chart temperatures, what the next steps might be. So you document who you talked to, what you talked about, and then document the time in a fraction. So as I said before, if you're not billing on time, then don't document the time. There's no value, but it's very important that you document the time if you choose to bill based on time. So let's talk about a few modifiers, because not all of our patients fit pigeonholed exactly into the CPT code books. So within the CPT code book in Appendix A, we find some modifiers. So the 22 modifiers that increase procedural services. This is when you say to the payer, this procedure was at least 25% tougher than it typically is. And it would be important if you attach a 22 modifier that you document well that there was at least 25% more work, and document why. You know, there were a lot of adhesions, or the cervix was very stenotic, or you know, whatever the reason is, this procedure took longer. And then also you can document that you are requesting an additional 20% compensation, whatever. You send it as much documentation as you can, and then the negotiation begins with the payer. So the 22 modifiers when the procedures are at least 25% more difficult than they typically are. This is an important modifier for those of us that do global care, like prenatal care, which is often billed in buckets of antepartum care, or antepartum, interpartum, and postpartum care. Whenever we deliver a service during a global period, so we see a patient for an upper respiratory infection at a prenatal visit. The prenatal visit is part of a global billing code, but the evaluation and management visit for the upper respiratory infection can be billed that day. And you would choose the correct evaluation management code, say you chose a 99213, and make sure you put a 24 modifier on it so that says this is an evaluation and management service that's occurring during a global period, so that the payer isn't confused that, well, but wasn't this a prenatal visit? And it's okay to provide these services on the same day as the prenatal visit. You just have to make sure that you clearly document the chief complaint, elements of the history, elements of the physical exam, and what your medical decision-making was. Same thing happens when we see a patient for complications in that 6 weeks postpartum period after they've delivered. They come in for subinvolution, they come in for mastitis, they come in for breastfeeding problems. We can bill an evaluation and management code and attach a 24 modifier that says this is a 6 weeks global postpartum period, but there is something that's significant and not typically part of the global bill that we are attaching to this service. Again, we've kind of talked a lot about the 25 modifier. It's very much watched by the Office of the Inspector General, so be sure that you use it appropriately. I'm not discouraging its use. I use the 25 modifier all the time in clinical practice because I'm usually always doing 5 things at once with a patient, but make sure that you document correctly. That's the key, is correct documentation that says that this is a separate service. If we are coding a preventive medicine visit with an abnormal findings or a problem, make sure that when the bill is submitted, and most of the time the people that do your billing will know this, you code the preventive exam as the primary code, and the secondary code with that 25 modifier then is coded second. So there's some sequencing rules with respect to billing. And so the most compelling or most urgent problem for the visit, the chief reason for the visit is always listed first, and then the secondary code is listed second. Many times we might do two procedures at the same visit. So a colposcopy with biopsy can be performed, and then we might also do a chemical destruction of a lesion. And so a 51 modifier is attached whenever we do multiple procedures. For those of us that catch babies, if we build a global code for antepartum, delivery, and postpartum, but it's a twin delivery, then we would build a global code representing all the prenatal care, but we would bill a 59409 vaginal delivery only with a 51 modifier because we delivered another baby. So that's two procedures, the whole global code, and then that extra delivery. You can have you can remove an IUD and insert an Nexplanon, and then you would put a 51 modifier on the lesser of those codes to represent that this is multiple procedures done in the same visit. Reduced services modifier is when we have to reduce the services for the procedure. For example, we charge for an IUD insert, but we couldn't get the IUD in. And so you put a reduced services modifier on a procedure that wasn't able to be accomplished, or we didn't perform all of the procedure. Make sure that when you perform a procedure that you also bill for the supplies. Many times if people leave off the supplies, that's a pretty costly omission. So make sure you bill for appropriate supplies when indicated with procedures. So these are examples of some HCPCS codes or supply codes that we might be used. So immunizations, injections, and other supplies. And then this is a slide to just talk very, very briefly about there are some services that are billed in buckets. So everything we do that's involved in routine, normal care is in a bucket, and maternity care is one of those examples. And when we go outside of the routine, then that's where the opportunity to bill an additional evaluation and management code presents itself. So we're not really going to talk a lot of, at all much about maternity care here, but just know that if you're in a maternity care global situation, but you're providing other services that are not routine, then use the correct evaluation management code with that 24 modifier. If we see someone for an episodic visit during pregnancy, the documentation has to include the history, physical, and medical decision-making. Choose the appropriate E&M code, the appropriate diagnosis code. Only code pregnancy as incidental if you're not a maternity care provider. The reason you code it if you're not a maternity care provider is because pregnancy may complicate your medical decision-making. You might need to code that, by the way, in addition to this problem, she's also pregnant, and that may change the level of code that you choose based on that complicating factor. Maternity care providers, we typically don't need to use that code because the payer knows that we also know that she's pregnant. So a sneak peek into next year. I'll be brief about this, but after all we just talked about these formulas and what is included, what's not included, coming January 1st of 2021, so a little over a year from now, history and physical examination will be completely eliminated from the formula. So all we just learned about looking at your history, looking at your physical exam, it still applies for the next year, so pay attention to it. But what they are now saying is we are choose the correct code based on what's medically, what the medical decision-making is, what is actually done, and then the provider will be required to perform and document a medically appropriate history and exam. So you will be only choosing your level of care based on medical decision-making or time, and then the time guidelines might change. And those haven't been rolled out yet, but just know that that will be a simplification of choosing our coding coming 2021, but we'll have to pay particular attention to that medical decision-making process. Also coming in 2021, again, will be modifying the criteria for medical decision-making. So it'll take out some confusing or less clear terms, define more key or important terms, and we will redefine, I say we, I'm not going to be doing it, the data element, like how much data is reviewed, that will be more defined. The 99201 will go away in 2021 because the only difference from the 99202 was the elements of history and physical, which will no longer be considered. So the 99201 code will disappear from the code set in 2021. And there will be a new prolonged services code that can be reported only with the level 5 new and established patient visits. So watch for those updates. There will be, I'm sure, lots of messaging around those changes in 2021. And so I'd like to conclude with a bit of great news for those of us that precept students, and that is this will go into effect next year, but the CMS has finally gotten on board with the attestation statement for working with students. And so what this says is that we can review and verify, which means sign and date, rather than redocumenting notes made in the medical record by other physicians, residents, medical physician assistants, and APRN students, nurses, or other members of the medical team. So we can simply sign and date, and that will document that we have reviewed it. We will not have to redocument that information moving forward. The focus is really on allowing providers to focus on providing good care and not jumping through some constraining documentation requirements. So this is new, hot off the press. It was just announced probably in the last 2 weeks. So that concludes my presentation. Thank you so much for attending, and I hope you found this information useful.